Here at the conference specifically, you've been talking about hemodynamic monitoring. Could you give us an overview of where we are with hemodynamic monitoring and how we could do it better?
Well, if I can take the latter first, what we can do better is to apply what we monitor. Too often, the critical care physician is very happy to measure a number of variables, blood pressure, cardiac output, and other things, but then there is no implementation of this information. So we need to, and that's what I just spoke about half an hour ago, how we can digest this information and apply it for the patient. And there is a lack of logical relation between what you measure and what you do. So in terms of monitoring, we are still relatively invasive today, at least with the central venous catheter, and in some cases with the arterial catheter. But that's it. We do not need to be more invasive than that. And it allows us to already have enough information to give fluids in particular without hurting the patient. There have been some recent trials attempting to give fluids without any form of reliable monitoring system in Africa. And the results were disastrous. It was actually harmful. So this brings us to the point that we need some form of monitoring. Wherever we work in the world, we need to monitor what we do. We cannot just pour fluids in a patient and pour vasoactive agents. That's not going to work. We need to define what the needs are and apply it correctly.
And the needs of an individual patient rather than a group.
Exactly right. We need to individualize our therapies. We need to personalize it. And that's a big problem in our field. It is that people have often tried to do big trials comparing A to B in very heterogeneous patient populations with no difference in survival, because then we look at the survival and there is no difference in survival. Why? Because some patients may have benefited from the treatment B versus A, but some others may have been harmed by this treatment. If you give transfusions without looking at blood losses or hemoglobin levels, it could be terrible to transfuse someone who doesn't need transfusions. So you could do a big trial and show that blood transfusions do not improve outcomes. Does it mean that we should throw blood transfusions away? No, I mean, of course, it's sometimes needed, but we need to know how to identify the patient who may benefit from blood transfusions. And that's true for any intervention. A monitoring system versus no monitoring system, this amount of fluid versus that amount of fluid. We need to individualize our therapies. But we can do it. Thanks to the monitoring systems, we can do it in the ICU. So let's do it.